Keith Mayakaduwage is a doctor, researcher, and advocate dedicated to advancing women's health through clinical care, research, and education. He is a resident in the Obstetric and Gynecology Unit in Monash Health, Australia, and an adjunct lecturer in the Department of Obstetric and Gynecology at Monash University. Keith's passion for stillbirth prevention, perinatal bereavement education, and equitable maternity care has led to extensive research collaboration with Savannah Care Victoria, the Stillbirth Center of Research Excellence, and the International Stillbirth Alliance. And we have another speaker. She is Billie Bradford. Okay, Billie. Uh, Billie Bradford is a registered midwife with more than 20 years midwifery clinical practice experience across a range of settings, from community-based continuity of care to tertiary hospital settings, as well as extensive experience in quality improvement, including mortality and morbidity case review and evidence-based policy and guideline development. Her work seeks to advance stillbirth prevention and maternity care improvement with a constant focus on addressing inequity and improving women's experience of care. Okay, they will be present their research. The research is midwife preparation for bereavement care, strengthening connections when supporting families after stillbirth. Okay, Keith and Billie, time is yours. You can present your research now.
You're muted, Keith.
Thank you for telling me, Billie. So thank you, Farah, for that lovely introduction. My name is Keith. I'm very grateful to be here today along with Billie. Thank you for the opportunity to BIDM for giving us the space to share this talk. Happy International Day of the Midwife, everyone. I'd like to start by acknowledging the traditional owners on the lands on which I'm gathering on today, and extend that acknowledgement to all Aboriginal people present today as well. Our topic today, as Farah correctly pointed out, is midwives' preparation for bereavement care, strengthening connections when supporting families after stillbirth. So I thought we'd start with some sobering statistics. According to the latest UNICEF stillbirth estimates released just a few months ago, 1.9 million babies were stillborn in 2023. This means that 1 in every 70 births ends in a stillbirth. Or to put another way, a stillbirth occurs every 17 seconds. So by the time we reach the end of this 30-minute talk, approximately 100 more babies will have been stillborn worldwide. While the report highlights some progress, showing a decline, as we can see, in the total number and rate of stillbirths since 2000, this rate is still unacceptably high, and there's still much work to be done. We also know that low to middle income countries are disproportionately impacted by stillbirth. So looking at the latest UNICEF stillbirth report, again, low to middle income countries accounted for about 87% of all stillbirths and only 68% of all live births in 2023. Looking closer at the data, stillbirths were concentrated in sub-Saharan Africa and Southern Asia, as indicated on the graph there, which together accounted for about 79% of stillbirths globally in 2023. In fact, 34% of stillbirths took place in 3 countries, India, Nigeria, and Pakistan, which together accounted for 29% of live births. It's very easy to get caught up in these statistics and numbers, but behind every number is a family grieving the loss of their child that they hoped to bring home. We know from the 2016 Lancet series that stillbirths have an immediate emotional impact on families and cause long-term adverse psychosocial impacts. However, empathetic and supportive bereavement care from healthcare professionals can help mitigate this trauma. However, parents have expressed that bereavement care that they receive is often quite suboptimal. A recent multi-center study in the UK found significant and unacceptable variation in post-stillbirth care, with some bereaved parents experiencing distress and insensitive interactions with healthcare staff. The study emphasized that every bereaved parent deserves compassionate and respectful care. A lack of familiarity with post-stillbirth care increases the risk of substandard support for grieving parents. This is particularly concerning as a recent systematic review highlighted that staff behaviors can have a lasting impact on bereaved families. Additionally, stillbirth, like we know, is disproportionately affects families in low to middle income countries, where multiple studies have documented the distressing and inequitable care that women endure. This study highlights findings from a qualitative in-depth series of interviews with 55 parents and health after stillbirth in Kabul province, Afghanistan, which shows that many bereaved parents experience significant emotional trauma due to disrespectful care, poor communication, and lack of privacy during and after the stillbirth. Healthcare providers, while aware of the emotional impact, felt ill-equipped to provide adequate support due to limited training, staff shortages, and systemic barriers within their health system. Another population-based study from the Enhanced team in 2020 highlights that 1/3 of women in India reported a negative social cultural experience following a stillbirth, and around 20% reported receiving insensitive or hurtful comments about the baby, and 70% were asked to forget about their babies as a means of coping. The consequences of inadequate bereavement education extends far beyond parents, though. Midwives and clinicians themselves are deeply affected. The Blossom study shown here highlights significant levels of professional burnout in around 400 Italian midwives interviewed. The findings show that nearly 2/3 experienced reduced personal accomplishment, and 1 in 6 reported emotional exhaustion with symptoms of PTSD present in almost a quarter. Tasks involving communication and direct support after stillbirth were rated as the most emotionally challenging, underscoring the urgent need for targeted education and support. Another qualitative study examining the experience of midwives in Istanbul shows that midwives form profound emotional connections with bereaved parents and often internalize their grief, leading to emotional distress and professional burnout. Without adequate support and training, many struggle to process their own feelings of guilt and helplessness, which can jeopardize their mental well-being and long-term commitment to the profession. So we can see that without proper training and institutional support, many midwives experience significant psychological distress and burnout when caring for bereaved families, compounding the emotional toll of their work. This lack of training not only affects clinicians' well-being, but also has direct consequences for the quality of care parents receive, leading to negative impacts on families. At the International Stillbirth Alliance, our group has been discussing these challenges and recognized the urgent need to better understand what is currently delivered to healthcare professionals in training. Identifying gaps in education will then allow us to advocate for targeted improvements in healthcare curricula. This led to our question today: is inadequate education within healthcare curricula, particularly at the university and undergraduate level, contributing to these gaps in bereavement care? I'll pass on to Billie just to continue.
So to answer these questions, we've launched an international survey of healthcare education in perinatal death and bereavement support. And this survey aims to answer the questions: what perinatal death education is provided to healthcare students, and how confident are healthcare students and new early graduates in their knowledge around perinatal death. And so for this presentation today, because it's International Day of the Midwife, we're going to focus just on the midwifery participants in this survey and on the data that's related to stillbirth. Okay, I've just pressed the advance button, but it's not moving forward. Was that me or was that you, Keith?
That was me. I can keep it.
Okay.
Yeah.
So in terms of the methodology, this was an international, and because the survey's still going, is an international cross-sectional online survey. The survey tool that Keith and I developed was co-designed with subject matter experts, including midwives, nurses, doctors, psychologists, and also bereaved parents. And to be eligible to complete the survey, you could be a medical, nursing, or midwifery final year student or graduate from within the last 5 years. And we recruited participants for the study through social media and other electronic communications and through the International Stillbirth Alliance network, which Keith and I are both members of. So in terms of the outcomes that we were looking at for this survey, they really were in two main areas. Firstly, we wanted to know about the current state of perinatal death education. That is what participants report having been taught about perinatal death. And secondly, how confident they felt in their knowledge around perinatal death and provision of bereavement care. And so we collected data and analysed it that's both quantitative and qualitative data by subgroup according to discipline and region of training. And as I said earlier, we're just going to focus on the stillbirth data from our midwifery participants for this. So we were pleased to have received a total of 140 responses from midwives, which was split roughly 50-50 between students and graduates. All participants met the eligibility criteria of either being in their final year of study or within the last 5 years. So we're going to look at that 140 responses now. So in terms of the demographics, reflecting our early career stage, the mean age of participants was just 29.5 years, and most respondents were between 20 and 29 years and largely female. So looking at their country of education, that most respondents did their education in Australia and New Zealand, which reflects really where we're from, pushing this survey out. And just a small percentage of respondents were spread across other countries. And so we would love more responses from other countries. So get ready to scan a QR code, which we will have later on.
Thanks, Billie. So moving on to the exciting things, the results. About the general intent of stillbirth in midwifery curricula. And so we asked participants just a simple statement, were you taught about stillbirth? About 87% reported receiving some level of stillbirth education in their training. This is somewhat reassuring, but again shows that region for improvement in terms of integrating stillbirth just in general in terms of healthcare curricula. We looked a little bit further though, so we explored the specific topics that participants were taught. So encouragingly, about 92% reported receiving education on the definition of stillbirth, and 84% were taught about risk factors. These findings suggest that the definition risk factors are fairly well covered in current training. However, the data also reveals significant gaps. Only about 40 to 60% of participants were taught about classification, epidemiology, and causes of stillbirth, and a similar percentage were taught about prevention, psychosocial impacts, bereavement care, and investigations. Just highlighting that only about 50% said that they received education specifically on psychosocial impacts and bereavement care, and just 43% were taught about the investigations following a stillbirth. These are obviously very critical aspects of care that parents heavily rely on healthcare providers to understand during bereavement. And while our sample size remains small, these findings already highlight a significant gap in training and reinforce the urgent need for universities to strengthen education in these essential areas. We then explored the primary methods of education delivery, shown on the left pie chart. We asked respondents to pick one answer for this question, focusing on the main way education was delivered. So most respondents, we can see here, about 44%, reported that they received education in person, while approximately 22 to 27% indicated that it was delivered either online or through clinical encounters. And around 5% stated that they engaged in self-directed learning. We also asked participants to identify the primary mode of provider for their education, again choosing one answer, and about 65% reported that their education was delivered by tutors and or lecturers. About 21% indicated that clinicians were the main provider, with a small minority indicating that they received education from bereaved parents through self-directed learning. And just to note that this is answering who was the main provider of that education. So bereaved parents may have been more represented, but they were not the main provider, which I think is an appropriate way to go about delivering this training. And just to make a note, the group that selected other for this category indicated that they received education through multiple ways, and so they couldn't pick a specific main way. Looking next at the confidence level in terms of the knowledge of stillbirth. So we asked participants to rate their confidence in each topic on a scale of 1 to 5. So 1 indicating no confidence at all, and 5 indicating extreme confidence. And so the star graph here illustrates the average confidence ratings across these different topics or domains. Encouragingly, respondents reported relatively high confidence in defining stillbirth within their country, with an average confidence rate of about 3.98 out of 5. However, confidence levels were lower across other key areas. Classification and risk factors for stillbirth received an average confidence rating of about 3.5, while confidence in stillbirth prevention was slightly lower than that. Notably, confidence was even lower for epidemiology, causes, prevention, and psychosocial impacts. Again, most concerningly though, the confidence rating was just 2.6 for bereavement care and investigations. As previously mentioned, parents rely heavily on clinicians' expertise in these areas during this critical time, and so a strong understanding of bereavement care and investigations is really essential for clinicians to provide appropriate support and guidance. These findings again underscore the need to enhance the quality of education in these areas, ensuring that midwifery students and graduates are adequately prepared to care for bereaved parents and address the key aspects of perinatal loss with confidence. We then explored the specific psychosocial impacts of stillbirth that are covered in healthcare curricula. Our findings revealed that while 94% reported being taught about grief as an element of psychosocial impact, other critical aspects such as shock, anger, guilt, anxiety, depression, and PTSD were significantly less emphasized. Again, this gap in education is very crucial to address, as compassionate bereaved care requires a deep understanding of the complex emotional responses that parents experience. And so again, without adequate training, healthcare providers may struggle to offer this compassionate and sensitive support that grieving families need. We then examined the specific aspects of respectful and supportive bereavement care that were included in midwifery curricula. And again, this analysis highlights some significant gaps that need to be addressed. Only 73% were taught about effective communication, including how to sensitively inform families that their baby has died or may die. Only 79% were educated on the recognition of parenthood, which includes supporting parents in seeing and holding their baby, memory making, and respecting culture or religious practices. When it came to shared decision-making, 74% reported being taught about how to involve families in decisions about the timing and mode and place of birth, as well as the perinatal autopsies and other investigations. Only 67% received training on effective support, including compassionate follow-up care, mental health referrals, emotional and psychological support, and guidance for families in future pregnancies. And again, most concerningly, only 62% were taught about organizational response, including their maternity department guidelines or protocols for bereavement care. Again, these findings highlight a clear need for improvement in bereavement care. And so if we want midwives and any clinicians to provide truly empathetic and comprehensive support, we must obviously teach them about how to do this through a structured training program. We then wanted to understand the experience that participants had in providing bereavement care. So among the midwifery participants involved, approximately 75% reported having been involved in bereavement care at some point in their practice. And so we asked these participants how prepared they felt to provide that bereavement care. For those who had not yet provided care, we asked them how prepared they would feel if they had to do so in the future. So only 5% of respondents felt very prepared, while nearly a quarter, 24%, said that they were not prepared at all. The majority fell somewhere in the middle, with 42% feeling somewhat prepared and 29% feeling moderately prepared. To understand what could have improved preparedness, we asked participants what would have helped them feel more confident in providing bereavement care. 62% highlighted the need for more education on this topic. 86% said more clinical experience caring for bereaved parents would have made a difference, and 53% felt that better support from colleagues and supervisors would have helped. Around 7% indicated other as the response to this question, and we gave them the opportunity to fill in some free text answer slots. These respondents expressed that they wanted to be more actively involved in bereavement care during their training rather than being sheltered from it. They emphasized that preparation comes from hands-on experience and practice, and a key theme was the need for more support in communication skills, particularly in breaking bad news and guiding families through difficult conversations. Others in this category highlighted the importance of better learning structures, clearer guidelines on paperwork, and more opportunities to engage with stillbirth care during their graduate years. Again, these findings on the whole reveal a significant gap between the expectation that clinicians deliver compassionate bereavement care and the level of training and support we actually provide. If we want to ensure that families receive the care that they deserve, we must prioritize a structured education program, clinical experience, and stronger support network for clinicians. We then switched the dial and asked how supported they felt to provide this care. Only 1/3 felt very supported, while the majority felt moderately to somewhat supported, and 8% did not feel supported at all. We then asked what would have helped them feel more supported, and the responses we can see here. About 67% expressed a need for better support in providing emotional and psychological care to families. Over 50% wanted more guidance on how to tell families their babies had died and how to practice shared decision-making. Just under 50% wanted more help in supporting parents to recognize their parenthood in accessing psychological services for themselves as healthcare providers. Again, around 6% indicated other as a response to this question, and their responses again involved more support with workload management and the need for better guidance on paperwork and legal processes, as well as more education on communication skills and behaviors, especially when navigating unexpected outcomes. Again, this highlights a critical issue. Supporting bereaved parents begins with supporting healthcare providers who care for them. Without adequate training and emotional support, clinicians may struggle to provide compassionate, high-quality care that parents deserve.
So we also reviewed, thank you, Keith. We also reviewed the written responses from participants that they had provided in the free text fields. And whilst we're still in the process of analysing those, because the survey's ongoing, we have identified 4 emerging themes. And these are gaps in structured education, a disconnect between theoretical and practical knowledge, workplace support deficits, and also system-level barriers to providing holistic care. So I'll just take you through those now. So in terms of gaps in structured education, a lot of respondents highlighted that their formal education didn't adequately prepare them for stillbirth-related care. University curricula and clinical placements were often described as insufficient, with midwives having to seek additional learning opportunities independently. And these quotes illustrate some of the aspects of this theme, that university is insufficient and substandard in addressing care and investigations around stillbirth, that stillbirth is not well taught in universities and in clinical practice, and that we delivered some modules on the topic, but further learning is by experience, which is not guaranteed in clinical placements. And I have participated in perinatal audits and have acquired some great insights. So while there was some foundational knowledge, which is obviously incredibly important, structured educational programs often lack depth in bereavement care. So moving on to the next theme, the disconnect between theoretical and practical knowledge, several midwives reported strong theoretical knowledge of stillbirth risk factors and causes, but lacked hands-on experience in actually providing the care. And they struggled to translate classroom learning into real-world practice settings, particularly when it came to supporting bereaved families. And so some of the statements that sort of illustrated this theme were, I have a good understanding of the theory, particularly around risk factors and causes, but I'm not confident with how to support families after the stillbirth. I have no practical experience. And also, much of what I know is theoretical and I've not had a chance to use it in practice yet. I have a general idea of the management of stillbirth, but as I've never seen this in practice, it's hard to retain this knowledge. Lots of theory knowledge, but no practical application yet. And whilst you might think, well, these are probably people earlier on in their career and that will come, we know that this foundational knowledge is important, but providing good bereavement care also requires development of those interpersonal skills around communication, empathy, and adaptability. And these are the type of skills that are best learned through direct experience. So simulation-based training is one, and supervised clinical exposure are two ways that midwives can be supported to develop these skills and confidence before they are encountering real cases or having to work independently in these situations. So moving on to workplace support deficits, our third theme. A lot of midwives described being inadequately supported when they were having those clinical experiences and managing stillbirth cases, which often led to distressing experiences and increased uncertainty about their role in bereavement care. And this was really emphasised with these sorts of statements. One midwife saying, "I was thrown in with zero support or training in my grad year. I was searching for policies and procedures on medications and the role of the midwife, when to give SINT, or in this case not, if a fetal heart rate was expected. It was traumatic, and on top of everything, I got in trouble for not wrapping the baby properly, even though I'd never used a cuddle cot before." I think many of us can relate to that sort of story. And another said, "More support to look after just the one patient, rather than still having to have a full patient load while also being expected to give emotional and physical care to the family with loss." So we know from the research that a lack of structured mentorship and emotional support can lead to distress and burnout amongst midwives providing bereavement care. So hospitals really should implement clear guidelines for bereavement support, ensuring that midwives are not left alone to manage complex emotional situations without preparation and support. A structured debriefing process and designated bereavement teams could significantly improve confidence and well-being and enable them to provide that sensitive and respectful care to families. So moving on to system-level barriers to holistic care, our fourth theme, midwives reported systemic challenges that hindered their ability to provide individualised, sensitive care to families. And this included a lack of culturally appropriate post-mortem procedures, just as these quotes illustrated. The midwifery aspect enabled good cultural care for this family, but the post-mortem process and transport of the baby to the mortuary needs more cultural consideration. And in another story, my family declined a post-mortem that they really wanted, as the post-mortem was unable to be done in a way that was culturally safe for them. And so these responses show that effective stillbirth care goes beyond clinical competency. It requires a healthcare system that accommodates diverse cultural and emotional needs, and institutions should ensure that processes such as postmortem care are culturally sensitive. Thank you, Keith. I'll hand back to you to bring us to a close.
So thanks, Billie. So bringing all this data together, it's very clear that significant gaps exist in bereavement care education for stillbirth. When included, the focus is often limited to definitions and risk factors, while crucial aspects such as actually providing compassionate bereavement care receives far less attention. These gaps are reflected then in confidence levels, with midwives reporting lower confidence levels in delivering bereavement care. And this lack of preparedness is reflected in the experience of students and newly graduated midwives, the majority of whom do not feel adequately equipped or supported in these situations. These gaps reflect midwives' abilities to provide compassionate care, often leaving them feeling unprepared and emotionally drained. The lack of knowledge can contribute to secondary trauma, increasing stress, burnout, when midwives are unable to offer the support that they wish. So what needs to change? Linking back to the conference theme today of making connections, midwives are not only clinicians, but also emotional anchors for bereaved families. Strengthening bereavement care education enhances their ability to build trust, provide culturally sensitive care, and foster connections that support healing. And so, midwifery curricula must be strengthened with structured bereavement care education, and clinical exposure to bereavement care should be increased. We also need to address the system-level barriers to ensure midwives have professional connections in the workplace to support and navigate this emotionally complex care. Improved training and mentorship will bridge the gap between theoretical knowledge and real-world practice, reinforcing midwives' role in shaping compassionate, connected care for bereaved families. This study in many ways is a call to action. We must educate midwifery students and all clinicians on stillbirth and bereavement care, advocate for global health policy to ensure that these updates are standardized curricula, and help future clinicians truly understand how to deliver compassionate, holistic care to bereaved families. By closing these educational gaps, we can improve outcomes and help reduce perinatal deaths for families worldwide. Like we've mentioned throughout the talk, our study is still open and we'd love some more responses from different countries around the world. If you'd like to scan this QR code, you'll be taken to the survey. Just to note that the survey is really focusing on that final year and any recent graduates within the past 5 years. And there may be more senior clinicians on the call today, but if you can take a screen grab or a QR code of this and share the link within your hospitals, your clinics, your universities, your any services that you work in, and that would be really very much appreciated. To expand accessibility, the survey is now available in English, Spanish, French, and Mandarin, with Arabic coming very soon. So please scan the QR code and feel free to get in touch with either Billie or myself on the email below. Thank you very much.
Okay, thank you, Keith and Billie, for your presentation. And now let's move on to our next agenda. There is the Q&A session. So you can unmute your mic or type your question in the chat. Okay, Raihana. Okay, Raihana, time is yours.
Can you hear my voice? Is it clear?
Yes.
Okay. Thank you for the presentation. It's such an interesting topic. I want to ask one question. So, in many developing countries, such as Indonesia, we still face situations where healthcare workers, especially midwives, are overwhelmed with a high number of patients. As a result, bereavement care often becomes a lower priority simply because there are always more patients in urgent need of help. So, in light of this, what do you think is the least that we can do to ensure bereavement care is not entirely overlooked? Thank you so much.
That's a really good point. And that touches on one of the system level barriers that we've found through the analysis of the free text answers. Billie and I both work in a tertiary service in Australia, and so we can both very relate to the high volume of patients that need to be seen, and that those responses have come through in our survey as well. I think obviously on a system level, there needs to be more staff hired, more birth unit capacity, more midwifery managers, more clinicians in general, to spread the workload of having a full patient load and also having to give bereavement care. But I think maybe in a achievable goal that maybe we can all take to our own units is maybe improving our communication with our in charges and with our midwifery managers or medical managers or whoever we're working with, and really just voice that concern that I have a significant patient load. This family really needs my one-to-one attention for a period of time. Is there anyone else who can perhaps maybe share the workload of my other patients so that I can fully attend to this family who really needs supportive bereavement care, which will most likely improve their outcomes for years to come. So I think that could be I guess we all need to, stand our ground a little bit more and maybe advocate for the patient that we're providing care to as something that we can maybe try and fix. But the best fix is fixing the system level barriers which exist. Billie, is there anything that you'd like to add to that answer?
Yeah, I just to say that that is something that we do hear from parents who have experienced a bereavement, that they're treated like they're not important anymore because their baby has died, when there's other families in the ward or in the area who have a live baby, and that is really very cutting to feel like it's not important. So even though their baby has died, for the parents, that this is still an ongoing emergency for them. And so and there are good reasons to provide good care for them, because if they have a bad experience of care, it really can increase the likelihood that they have complicated grief and are less able to resolve their grief. And unresolved or complicated grief can lead to very serious psychosocial complications for the parents, including even suicide. So and so looking after that family well is important. And I guess just like all of midwifery work, we're constantly having to advocate for why what we do is important. And it's not just a nice to have to be kind to people. It actually enhances their health and their engagement with healthcare services in future and so on. So it's just, unfortunately, once again, it's just about us being advocates constantly, and that people who experience the death of a baby also deserve compassionate care and our time. But I agree, it's a difficult one.